I'm Eric Strong from the Palo Alto Veterans Hospital and Stanford University. Today, I will be talking to you about shock, focusing on its recognition and management. Here are the learning objectives of this talk. First, to be able to define and recognize shock, as well as understand its four major subtypes. Second, to know the major etiologies of the shock subtypes. Finally, to understand general treatment strategies, focusing on IV fluids and choice of pressor. Before I begin, I would like to offer an initial disclaimer. Though the body of primary scientific literature on the management of shock has grown significantly in just the past 2 to 3 years, there remains relatively little in the way of comparisons between one medication versus another, or between one treatment strategy versus another. Therefore, there exists substantial variation in the management of shock as a consequence of differing emphasis on physiologic principles, institutional preferences, and personal experience. So now, what exactly is shock? This term is used in many different ways among different people. Lay people and doctors on TV tend to use the term very broadly to encompass a wide range of pathophysiologic and psychologic states. However, as medical providers, we should reserve its use for something a bit more specific. I like to think of shock as a physiologic state characterized by a systemic impairment in oxygen delivery as a result of reduced tissue perfusion, almost universally mediated by low blood pressure. There are rare examples of shock in which blood pressure is normal, which we will mention a little later, but the overwhelming majority of patients in shock have hypotension. Note that a diagnosis of shock depends not just on the blood pressure, but also on indications of systemic hypoperfusion. Let's take a look at what some of those indications can be. While the underlying specific cause of shock may have very specific findings, such as hematemesis in the hypovolemic shock accompanying a variceal bleed, or the ST elevations in cardiogenic shock triggered by an acute MI, the following list is of signs and lab abnormalities that are consistent across all forms and etiologies of shock. In the cardiovascular system, we have hypotension, elevated lactate, and an elevated troponin. Neurologically, patients often demonstrate altered mental status of some form. Many pass through a sequence of stages whereby they first become agitated, next delirious, then somnolent, and finally comatose. Of course, this sequence isn't universal. For example, some patients may not get agitated or delirious, becoming somnolent. In the renal system, urine output will drop, and a rise in the BUN to creatinine ratio will frequently precede a frank rise in creatinine that can eventually lead to kidney failure. A large array of hematologic abnormalities can be seen, depending on the underlying etiology. The one common problem across subtypes of shock is dysfunction of the coagulation cascade, which can lead to DIC in extreme circumstances. The skin is frequently cool and clammy, except in the early warm phase of septic shock, and there may be cyanosis of the fingers and toes, suggestive of poor perfusion and poor oxygen delivery to those areas. Hypoxia and particularly tachypnea are also common, irrespective of the underlying etiology. Finally, within the GI system, ileus is frequently seen, along with extreme elevations of AST and ALT above 1,000, commonly known as shock liver. Even if the initial etiology of the patient's shock has nothing to do with GI hemorrhage at all, poor perfusion of the gut can lead to minor diffuse hemorrhage that may not be directly clinically relevant, but can lead to a positive fecal occult blood test. Regarding this list of signs and lab abnormalities, there are no guidelines or criteria regarding how many need to be present or which systems need to be involved in order for shock to be present. But a combination of multiple abnormalities from more than one system, particularly in the presence of hypotension, should definitely trigger the medical provider to become concerned about the presence of shock. Now I would like to take a short digression to discuss the physiologic description of what's occurring within the cardiovascular system during shock. This is very important because a basic understanding of the physiology will allow us to understand why shock is divided into separate subtypes, and the different subtypes are treated very differently. First, Let's begin with Ohm's law. For some reason, I find that almost no medical students can remember the equations of fluid mechanics relevant for the cardiovascular physiology, but nearly everyone remembers V equals IR, or voltage, which is a gradient in electrical potential, equals the current times resistance. We can apply Ohm's law to hemodynamics. Now the pressure gradient in the cardiovascular system equals blood flow times resistance. If we are a little more specific with our substitutions, we now have perfusion pressure equals cardiac output times systemic vascular resistance. Perfusion pressure is MAP minus CVP, or mean arterial pressure minus the central venous pressure. Next, we know that cardiac output is a product of heart rate and stroke volume. Finally, that stroke volume is dependent upon preload and contractility. Therefore, low perfusion pressure, which is a reasonable surrogate for shock, can be caused by low heart rate, low preload, low contractility, or low SVR. From here, let's discuss the four major subtypes of shock. First, hypovolemic. Hypovolemic shock is caused by low preload. Next, distributive. Distributive shock is caused by low SVR. Then cardiogenic. Cardiogenic shock is caused by low contractility. Finally, obstructive. Obstructive shock is also caused by low preload. Well then, you may ask, what is the difference between hypovolemic and obstructive shock? The low preload in hypovolemic shock is due to lack of total intravascular volume, while the low preload in obstructive shock is due to a physical obstruction to LV filling. One might next ask then, what about shock caused by low heart rate? What subtype is that? This brings us to a few additional subtypes to mention. First, there is what is occasionally referred to as arrhythmogenic shock. As the term implies, this is shock that arises as a consequence of an abnormal heart rhythm. Profound bradycardia leading to low cardiac output falls into this category. Also, extreme tachycardia that leads to low cardiac output by insufficient diastolic filling time is also included here. Next is toxin-mediated shock, referring almost solely to the toxins of carbon monoxide and cyanide, both of which can lead to impaired oxygen delivery and or utilization through mechanisms not requiring low blood pressure. Because both of these additional subtypes have unique mechanisms and very specific treatments, we won't discuss them more during this particular lecture. Now that we have some familiarity with the subtypes of shock, how do we go about recognizing which subtype is present in any particular patient? This is critical to do very early and quickly, as the management for the different subtypes can differ significantly. There are four basic physiologic parameters that can help us distinguish one subtype from another: central venous pressure, systemic vascular resistance, cardiac output, and the temperature of the extremities. Obviously, some of these are easier than others to quickly determine at the bedside. Let's first take a look at hypovolemic shock. The CVP is low because of low intravascular volume. As part of the body's compensatory mechanisms to try to maintain adequate blood pressure, SVR is very elevated. Regarding cardiac output, although these patients are typically quite tachycardic, which might lead you to think the cardiac output is high, it is actually low due to the fact that the effect of the low preload outweighs the effect of the fast heart rate. Finally, the extremities are typically cool and the peripheral arteries are clamped down to help raise blood pressure and shunt blood towards the vital organs. Next, obstructive shock. CVP is high because of backup in pressure as central venous blood meets a physical obstruction to flow within the cardiopulmonary systems. SVR is elevated for the same reason as in hypovolemic shock. Cardiac output is low because of low preload in the left ventricle. Finally, the extremities are cool. In distributive shock, CVP is usually low, at least initially, because the vast majority of patients with distributive shock also have a component of hypovolemia as well. SVR in distributive shock is low, as that's the predominant physiologic abnormality. Cardiac output can either be high or low, depending on the presence or absence of sepsis-induced cardiomyopathy. The extremities are usually warm, but can be occasionally cool, particularly if the patient has been in shock for a while, or if cardiac output is low. Lastly, with cardiogenic shock, CVP is high, SVR is high, cardiac output is low, and the extremities are cool. Occasionally, in cardiogenic shock, SVR is so high as to balance out the low cardiac output enough that the peripheral blood pressure is actually normal. This can be a very difficult case of shock to diagnose, as the affected patient may have all of the consistent signs and symptoms of shock but normal blood pressure. Luckily, this scenario is relatively uncommon. I would like to briefly go through the major etiologies of the shock subtypes. Hypovolemic shock can be further divided into hemorrhage-induced, such as GI bleeds or from trauma, and fluid loss-induced from diarrhea or third spacing. Hypovolemic shock from third spacing is probably most commonly seen in severe acute pancreatitis. There are essentially 5 distinct causes of distributive shock. They are sepsis, anaphylaxis, myxedema coma from profound hypothyroidism, adrenal crisis, and neurogenic shock from acute spinal cord transection. Some people have advocated taking myxedema and adrenal crisis out of this category and forming a separate subtype for endocrine shock, but this has not caught on widely yet. Cardiogenic shock is usually due to an acute myocardial infarction, but can also be seen in myocarditis, acute aortic insufficiency, such as that which can accompany bacterial endocarditis, and papillary muscle rupture. Arrhythmias are sometimes put into this category, but as mentioned previously, are quite distinct in their management and are probably best separated out. Although this is never seen at most hospitals, at Stanford, heart transplant rejection is another important cause of cardiogenic shock. Lastly, obstructive shock can be caused by a massive pulmonary embolism, tension pneumothorax, or cardiac tamponade. One important caveat to categorizing a patient in shock is that more than one type of shock may coexist in the same patient. There are 2 scenarios in which this is most commonly seen. First, as previously mentioned, most patients with septic shock have some degree of concurrent hypovolemia. This is the consequence of poor PO intake while in the earlier stages of their illness, as well as due to leaky capillary membranes and third spacing. Second, septic shock can induce a de novo cardiomyopathy, one which can be completely reversible with successful treatment of the underlying sepsis.